Today we have Jill Alvarez, a 42-year-old female admitted on February 4th at the General ER with the chief complaint of abdominal pain and smelly diarrhea for the past 2 days. Patient states that she has been taking Imodium for the past 2 days with no resolution. She reports a C. diff infection 4 months ago and was treated with a 10-day oral vancomycin regimen after being treated with levaquin for her UTI infection. She also reports her first recurrent C. diff infection 2 months ago and was treated with a tapered vancomycin dose due to azithromycin for her sinusitis infection. For social history and family history, it was non-contributory to her recent visit, her today's visit, and then review of symptoms, she reports watery stools and abdominal cramping. For allergies, she reports penicillin after taking amoxicillin back in 2006, and she reported nausea and vomiting. For home meds, she's currently taking allopurinol, QVAR inhaler, and the ProHair inhaler as well. So with the initial visits, her physical exam report, her vital signs were within normal limits. White blood counts was elevated at 14,500. Serum creatinine is also 1.4, potassium at 3.3. And then during the physical exam, we noticed abdominal tenderness with hyperactive bowel sounds. For stool output, it was 6 loose stools, and then with the COVID test, it was negative. They've also done a C. diff PCR test, which was positive for C. diff, and then for her abdominal pelvic CT scan, it was also positive for colitis. Let's see. They've also obtained two GI PCR blood cultures for the panel, and then stool samples the next day on 2/6, and it was negative for any pathogen. In her labs, her white blood count was trending down at 13,900, and serum creatinine was trending down with the creatinine clearance of 48 milliliters per minute using the ideal body weight of 50 kilograms. There was a potassium of trending up towards normal limits of 3.6, and the stool output of trending down to 2 loose stools. Vital signs were also within normal limits. With the ID problem and evidence, we found out that the patient is experiencing subsequent non-severe C. diff infection evidenced by, a patient is having another episode of C. diff infection within the 8 weeks from the previous episode. Patient symptoms of ER symptoms of the abdominal pain and smelly diarrhea for the past 2 days. We found the physical exam of distended hyperactive bowel sounds, and then the outtake of more than 3 unformed stools within the last 24 hours. Because of the C. diff PCR, it's highly sensitive. It was positive, and the abdominal pelvic CT scan was positive colitis, and then additional with the risk factors of additional antibiotic use previously within the last 6 months. So with that, our pharmacological goals is to alleviate signs of symptoms of C. diff diarrhea such as abdominal pain and diarrhea, to minimize complication of C. diff infection, and then to prevent the spread of C. diff infection. For non-pharmacologicals, we want to use supportive care with fluid and electrolyte replacement therapy if needed. We want to consult the gastroenterologist and or an ID specialist if available to control the infection. And then we want to infection control prevention by talking to the patient about cleanliness and washing hands. For pharmacological plan, we want to stop the vancomycin 125 milligrams every 6 hours, and then stop levofloxacin 500 milligrams every day. We want to start fidaxomicin 200 milligrams by mouth twice a day for 10 days, with the day 1 of therapy is today. Continue his home meds such as allopurinol, Qvar, and albuterol. And for efficacy monitoring, we want to look out for clinical cure of C. diff infection by resolution of diarrhea of less than three stools for 2 consecutive days. Rate of recurrence of C. diff infection, and then the time to resolution of diarrhea. For safety monitoring of fidaxomicin, we just want to monitor the GI side effects such as nausea, vomiting, and abdominal pain. Thank you.